I met Dr. Coburn a little over a year ago. We invited him to present to us at the Medical Society at a board meeting. And it was very interesting and a good speaker, I will say. Dr. Coburn is the CEO and Medical Director of Health Quality Partners, a not-for-profit healthcare quality research and development organization based in Doylestown. The interesting thing, and I think the topic of Dr. Coburn's talk will be, there is a lot of pilots in improving care. There are a lot of ways and experiments and trials to improve care. The design and development of one that actually works is the challenge, and I'm looking forward to hearing what he has to say. Here. There he is.
Thanks. Thank you. Sorry for being a little late getting wired up. Thanks, Gus. Good morning, everyone. Appreciate the chance to be here. It's a real privilege, and I hope that this will be a little bit of an interesting dialogue with you all. How many folks are, and you can answer multiple times to these questions. We're going to ask about who you guys are. How many folks would say you have a significant role in HIT? Not surprising, since that's the nature of the summit. How many would say you have a significant direct role in delivery of health care? Okay, and again, you can answer more than once. Health plans? Not a lot of health plan representation, a couple folks. Okay. Public health? Okay. What am I leaving out? Anybody here that's representing something else? Okay. All right, what I'd like to do is start kind of conceptually and then move into a case study of an actual example of some work that my team has had have the privilege to do. And I want to start conceptually, and I think it builds off of what Cam was describing about the transformation of healthcare, and talk about design. This slide is not meant to be a product placement opportunity for these products, but when we think about great design and we ask ourselves, are we really designing optimal products and services? These are a few that just I selected. The car is a Lamborghini, my 15-year-old son's favorite model. The aircraft is an F-22, iPad on the lower left. And anybody want to guess what the performers in the middle are from, where they're from? Cirque du Soleil, yeah. So, and I use these kind of images to sort of talk about design in a conceptual framework. Usually when we see something that's tremendously well designed, we think of them both as being very high performance in terms of a very intentional aim they have, and being kind of, you know, beautiful, kind of aesthetic, kind of elegant in their appearance and service and use. How many things in healthcare do we have that you think match great design, that you'd say, oh, this is an exemplar of absolutely great design in delivery of healthcare? Okay, so that's kind of the topic, and where a way of thinking about that might be helpful to us. How many folks here feel that you have sufficient time dedicated in your daily work to thinking in a serious way about designing the work you do? One hand, two hands. Anybody else? Three, maybe? All right, for most of us, it's a luxury. You know, most of us, it's the press of the day to manage the daily objectives of your system. And the idea to sit back and start with a blank piece of paper and say, what are we really trying to do here? What would be a better fundamental design is really very uncommon for most of us, even people in very important roles in healthcare. I think that's a critical issue. So what I'd like to do is give you a little bit of an introduction about my organization and our work, very briefly, to kind of frame out where I'm coming from and what my background and my team's work has been. Talk about design and its importance in healthcare, kind of conceptually. A couple simplistic examples of what I intend to convey here, and then go into a specific case study of an actual work that we've done that I think sort of shows how this kind of application of design thinking can be very helpful. My organization is a not-for-profit, And like the handful of you that have the luxury of actually being able to immerse yourself in thinking about design, it's really all we do. We are an unusual kind of R&D shop that really tries to design, implement, and test new healthcare delivery models. And we came to that from a whole litany of prior lives I won't go through, but they all centered around population-based care management in various health systems and health plans that all imploded under the wrong alignments of financial incentives to do this work back in the 90s. So the issue here, so what our team is really focused on is population-based models, designing and implementing and testing those models. Most of our work is focused on a couple big areas. One in particular, which I'll spend a little bit of time talking about later, is our Medicare coordinated care demonstration. This was one of the very first demonstration projects. It dates back to the '97 Balanced Budget Act for looking at care coordination models for chronically ill, older Medicare beneficiaries. We've also been able to take that same model and with a partnership with Aetna, look to apply it to their high-risk Medicare Advantage members. And we've also been invited to participate in different health system redesign initiatives and care models that are listed on the slide. Just, I won't go through this, but the work that we've done and the opportunities we've been given to do this kind of design work has not just been generated by us alone and our team, but lots and lots of people who are starting to really work hard to puzzle this through and figure this out. And it's been through their support and help that we've been able to undertake some of this work. So design. Now, some of this stuff is going to sound incredibly simplistic, and I don't mean it to be sounding either in any way at all condescending or glib or anything. I think that, again, because we don't often get a chance to sit back and start from first principles, sometimes I think we take some of these things for granted. But if we want to create a better system, we have to first imagine what that's going to be, right? So if we can't think of what it should be and we can't design it, we're certainly not going to see it realized. And I think the concept of design is very underappreciated, misunderstood, and underused. And so let me just briefly touch on that. Underappreciated because I think that when we think about the best services and products, the most extraordinary human accomplishments, they don't happen by chance. They're often done with painstaking obsession to detail and design. And that's what gives them their capabilities and high performance. Yet we don't sort of hold ourselves to that standard often or don't have the opportunity to in our work. I think it's misunderstood because a lot of times, and I've been in many, many meetings, and I'm sure some of you have, where there's a strategic objective set, and then it's kind of like you turn to the head manager of that unit and say, manage us to that objective. Get us there from here. And the confusion between managing to goals and redesigning a system, I think, is a distinction that people miss a lot of times. And we often ask folks in leadership positions in our organizations to do pretty much the impossible. With the existing system as it is, with the existing array of resources and data feeds they have, we expect them to manage to our goals instead of fundamentally saying, you know what, our system isn't capable of achieving those goals without being redesigned. And so I think we think that we can often manage our way to another level of performance and forget that a lot of times it needs to be redesigned. And I think we underuse the idea of saying, let's do a timeout, let's stop and ask ourselves, do we have all the blocks in place? Do we have what we need? And if we don't, how can we redesign? And I think for most folks, this sort of graphic in the middle is to convey that if you want a high level of effectiveness, and you start off with a weak or an inadequate design to accomplish that purpose, there's almost no way you can achieve a high level of effectiveness. And again, I know this might be stating the obvious, but I think we forget it a lot. And we think that if we implement more effectively, if we have Six Sigma, if we drive to defect-free performance in the setting of a design that's actually not designed to achieve adequately what we want, we're going to achieve effectiveness, but we won't. Put a different way, You know, Einstein, this is one of his many famous quotes about problems can't be solved at the same level of thinking that created them. I think design is asking us to think at a different level for the problems we have and the solutions that we can create. And Carl Weick and others that talk about high reliability organizations use this term of sense making in organizations. The other thing that good design will do for you is it'll help everybody understand where they are in relationship to the goal, the aim, the strategy, the daily task. And if you're in a system that's not well designed, you kind of know that you're supposed to be pushing towards something, but you're not exactly clear how you and all the other parts are supposed to work very integrally to get there. So you really can't overcome an ineffective design. Now, as Cam was mentioning, we're one of the highest cost, we are the highest cost country by far, 2 to 3 times for most of the developed world in our healthcare delivery. Our outcomes are not particularly stunning when you compare them to those countries in terms of population health. And lots of people have been thinking about this challenge. How many people have seen either of these two references? The top one is a report from the Institute of Medicine and the National Academy of Engineering that talked about this issue of redesigning a system, taking more of a systems approach to our healthcare delivery, building a better delivery system. The bottom one is more recent from the Institute of Medicine, talking about how can we take primary care and public health and integrate those two in a more effective way. And both are really good references that I would refer folks who are interested in this to reading. You can get them online from the Institute of Medicine. And so there's been efforts around this. Now, why hasn't this sort of catalyzed an intense focus on design? For one, I think a lot of these things, there was a couple of hands that went up in the room, but for one, I think a lot of this work is not well known by folks. Two, it is a little dense. I mean, if you read the engineering one, you have to really have an appetite for this stuff. It's not as exciting as watching Cirque du Soleil. So you have to really be up for it. And two, to be fair to these folks, although they're very good pieces done, they still leave you with a kind of a conceptual direction to try to think more seriously about how to apply and consider these issues. But they're not really a blueprint. They're not something that you can take and say, okay, let me go back to the leadership in my organization and think about how we can do this. So they're very enriching, but you still have a lot of work to do after you read them about what you're going to specifically do in your environment and context. Now, this is a terrible example, so I want to preface this from the beginning. This is a lousy, simplistic example, but I want to use it anyway. And it's lousy for a couple of reasons. Because one, when you're doing real design, you don't already have the finished product, right? So this is an example I'm going to give you just to think about design decisions as you go through a process like this. So this is kind of lame because I've already listed the end opportunities you can have. But when you're really doing design, you don't know what the end is going to look like. You don't know what kind of vehicle or car or service you're going to come out with. You're building it as you go. But if you start at the left of this slide and you say, what's the big idea? And this is where I really feel we often shortchange ourselves in whatever line of work we're in healthcare delivery. We often don't spend enough time talking about what is the big idea we're trying to accomplish in our designs. We often go immediately to how do we make this department or unit more profitable, more efficient, gain a market share. We go to the kind of the tactical, strategic, enterprise, sub-enterprise elements of what we're trying to accomplish instead of moving upstream to big ideas. So in this simplistic example, the big idea is transportation. We want to move human beings from one place to another. And then, okay, where do we want to move them? On the ground, in the air, in the water? Well, let's pick the ground. So that's our first decision design point. And then the question is, okay, so we're going to move them around on the ground. How big a carrying capacity, how much mobility, what size of this thing do we want to make that happen? And we could pick from car, motorcycle, truck, bus, train. We can make some basic decisions there. Let's pick car. And then you have a whole bunch of other decision design points around the range and efficiency and affordability, et cetera, et cetera. And you kind of go through this step by step. And you can create as many of these layers as you want. You can embed in those columns of design decisions whatever you think are the important value propositions and what you're trying to create. And at the end, you'll come out with some final decisions about what the car, the end product, should look like that's going to ultimately be the means of transportation. And you know you've lost your way, for sure, and this is where I think there's some applicability to healthcare. You know you've lost your way when the end product doesn't achieve the initial big idea. So if we were to create something that at the end didn't achieve transportation, we went off the rails somewhere in the design process, right? So we'll get to an equivalent discussion about this for healthcare, because I think some of that may have happened with our healthcare system. So if we were to do this, if we were to talk about the framework of thinking about that kind of approach for healthcare, what's our big aim? How many times are people in meetings where the big aim is something other than maximizing the health of the population you're serving? I would say it's the minority of meetings I'm in where somebody says, this is our big aim. We're going to maximize the health of these people. We often don't start there. We start all kinds of other interesting starting points for what the aim of our design is going to be. If you have a good aim, though, you can use it to help guide your decisions, those decision points in your design, and reference back to that big aim. Am I still on track with the big aim? Am I making the right kinds of decisions and value propositions? And then the other thing I would suggest to you, and again, we'll get to a case example of this to give you some sort of concrete reality around some of this, is to resist censoring from the beginning your ideas around design decisions because of a presumption of resource scarcity. I mean, it's amazing to me that we live in the wealthiest country in the world, that we spend 2 to 3 times more resources than any other country on healthcare, and yet every meeting I'm in where people start talking about redesign, they say, well, you know, don't go there because we don't have the resources. We don't have the resources, right? And so I think we self-censor what's possible because we say from the beginning, first of all, we might pick an aim other than maximize health, and then we start putting in some self-censoring things before you even get started with the design decisions. And of course, along the way, designing for reliability and effective implementation is a very helpful piece to kind of bear in mind. End goal would be measurably better health, and there's some assumptions built in here. And this relates back to what Kim was referencing about triple aim. The assumption that we used in the work we've done is that if you really keep to that primary aim of maximizing health, the triple aim will follow. You really can't maximize a population and people's health without figuring out a way to be patient, person-centered. Because after all, to a large degree, the definition of health is going to be defined by them, not by us. So that kind of forces that part of the design, I think. And then this is the big leap for most people, is the assumption that if we really did a great job maximizing health, we could save enough money to really make this thing work. This is where we lose a lot of people. Because lots of folks have tried, you know, good things, and they don't necessarily always get enough of improvement in health outcomes and save money enough to make it self-sustaining. And then beyond those two assumptions, the recommendation I'd offer is suspend all the rest of the assumptions you can. The roles that people should play, the limitations of our data access, control issues, market issues, et cetera. And this is where I lose everybody else that I haven't lost in the prior steps to this. But if we don't do this kind of thing, if we don't engage in trying to stretch our approach to thinking about new design, it's unlikely we're going to get them. We're going to continue to design within the same constraints and assumptions that we've been working within all along, and we're going to continue to get similar models that we have. So applying this approach, and this is kind of related directly to the work we've done, and I'll start to sort of transition into the case study side of this. If you take this from the perspective of what my team has tried to do, we said, okay, what's the big idea? Well, we're going to go for improving or preserving health. We think that should be the big idea. And then you can, one decision point you could put in the first rung there is, well, which population are we going to be targeting? So we've selected for most of our work the chronically ill older adult population. It is a huge driver of cost. It is very complicated. I think most folks would acknowledge that our system does perhaps worst of all in caring for that population. And then we realized pretty early that that is a really big challenge. That is a very complicated set of issues for that population. And actually, before we could even start to get into nitty-gritty specific design decisions, we even needed to decide on a framework to help us make decisions about what we're going to do for them. So we've gone ahead and called this an advanced preventive service model or concept. I'll spend a couple of minutes talking about this in more detail, but the three basic elements of it have to do with assembling the broad and deep set of preventive interventions from the best available information and evidence base out there that could help this population. Assemble as many of those as we could find. Has to do with defining in advance what you want the delivery model to have as key attributes. And then thirdly, how you're going to continue to learn and improve upon what you started with as a key component of the design from the get-go. So that's what we're calling an advanced preventive service. And then within that framework, you can pick all kinds of specific things that you think will get you there in the final phase. And at the end of it, you have what we're calling a community-based care management model, which I'll describe to you in a little bit. Okay. So in terms of this advanced preventive service idea, and I'm not trying to hawk this as the end-all be-all. All of this stuff is work in progress. But it's been very, very helpful to us in terms of organizing our thinking and organizing the way we try to design a coherent model. The first thing is to assemble as many of these best practice interventions for prevention as you can. Prevention interventions that have been shown to work for the target population you're trying to improve the health outcomes for. And when you think about it, for folks that are familiar with this terminology, this kind of, syntax or categorization of preventive services, if you think about trying to embed in your framework, in your portfolio of services, the full spectrum of primary, secondary, tertiary, quaternary preventive interventions. So for folks that aren't familiar with it, I'll try to quickly do this justice. So primary is you want to attempt to prevent the condition in the first place. So if you're talking about hypertension, for example, you would want people to maintain a good body weight, be active, have low sodium intake, and never get hypertension. That would be primary prevention. Secondary prevention is they have hypertension, but you want to keep it under control so they don't have complications from the chronic illness. So you try to keep the blood pressure well managed and on medication, lifestyle changes, and so on. Tertiary prevention is they have hypertension and they've had a complication, let's say a stroke. And now they're not getting around as well and their gait is unstable. And you want to prevent them from having further injuries due to that, further complications. So you want to make sure they have a walker and they go through rehab and everything is as safe and as effective to keep them from having any further complications. Quaternary prevention, I actually didn't know. I have a little bit of a public health background, and I was new to quaternary prevention. Anybody know quaternary prevention? So this is my personal favorite. Okay, quaternary prevention is preventing the things that we do in delivery medical care that harm patients. Okay? So if you could imagine constructing a portfolio of all the things that you know about for chronically ill older adults that would do these kinds of preventive interventions and put them together in a package and deliver them consistently, reliably, with a good user interface, a good patient experience, we thought that would be pretty cool. So to that end, there are these key specs and attributes that we thought were going to be important in doing this. And I know many of you have thought about these things and are working on these as well. Understanding individuals' needs and preferences, high touch, continuous, longitudinal. Okay, because what we observed in the data is that the folks that reach a certain level of complexity in chronic illness as they age, usually you can't, reverse the clock. There's no magic potion, and the chronic illnesses remain chronic illnesses. And if you don't do something that's going to maintain a continuity of support, I know we're very episodic driven. We get paid for episodes. We think about everything as an episode. We close out episodes. But that's not how people's lives are if they have 3 or 4 chronic illnesses and they're 85 living alone. It's all one big episodic journey for them. So despite the fact that we think about it as a visit to the doc, a visit to the hospital, a visit to the rehab, it's not the way they experience it. Okay, and collaboration is huge. Obviously, no one magic component of a team or a data system or anything is going to meet the needs. There are tremendous complexity and challenges here. So collaborating effectively with healthcare providers and other community resources is essential. And we are pretty fanatical about process monitoring. We have 200 process measures for our nurse-based community care management model. Many of them are statistical process control measures. How many people know what statistical process control measures are? Okay. It's still, unfortunately, a minority of folks in healthcare. It's a very, very important approach to knowing whether what you're delivering reliably and with how much variation. It goes all the way back to Deming and Schuhart and the Bell Labs and all this kind of stuff. And it's a really cool kind of way of mapping out data points, usually in a time series, and using some simple rules about whether a change is a real change or likely due to variation, kind of noise in the background. And then trying to be as data-driven as we can and disciplined about learning how to improve, because no design out of the box is going to be the end-all, be-all, and ours certainly isn't. Just to give you a feel for this idea of packaging as many services in a module that you can, I'm not going to go over this in any detail. This is meant to kind of give you a gestalt. From when we began back in the late 90s to today, and we haven't updated this slide, and there's a few more layers. This has been an evolutionary process of making design decisions. Each of these layers is a design decision. Some of these layers started and then stopped. Some we started anew. The thickness of the layer is kind of meant to, in a crude way, represent the importance of that particular intervention. But to give you a flavor for this, back in the old days, we used to have a nurse care manager who was a specialist in diabetes, and one who's a specialist in heart failure, and one who's a specialist in chronic pulmonary disease. And then we thought, okay, this is going to be easy because we have people who can really get that down, and for folks that have those conditions, we'll just send them the respective nurse they need. Some of you guys who have done this probably know the punchline to this. They all wound up with 3, 4, 5 nurses, right? Because the more complex, the longer people are living, the more complex and multifaceted their chronic needs are. It became not only unwieldy, but really a bad design. It was very inefficient, and it was very confusing for patients, and it was just a poor model. So the big, I think it's the big yellow bar down at the bottom here, is when we decided, okay, we really needed an integrated care manager, and sorry, but you're going to need to now learn the guidelines for heart failure, diabetes, chronic pulmonary disease. It was forced on us by the nature of the work. So it was a design decision. So along the way, we've added things like gait and balance training for fall prevention, lots of structured education for weight loss, weight maintenance, seated chair exercise, lots of things that we knew from terrific research that had been done really impact favorably the health outcomes of this population, but that you were hard-pressed to see reliably provided to everybody who could benefit from them in our current system. We said, well, let's just package them all together and provide a resource to do that. Now, I won't go into this in too much detail, but obviously design and implementation do overlap. You do need to design for good implementation. So we actually borrowed this theoretical framework. We were doing this ourselves, kind of grassroots, but this is a kind of a nice paper for people that are interested in this sort of thing, about core implementation components. And basically the idea here is that each of these boxes represent elements of your implementation strategy that if you do them well, you're likely going to deliver a reliable, effective service. If you do them poorly, you're likely not. And this idea in the middle that they're integrated and compensatory means that one feeds off the other, and if you're strong in one, it can make up kind of for a weakness in the other. So if you go around this cycle, you see it talks about recruitment and training and pre-service training and ongoing coaching and mentoring and development. And we have found this to be extremely relevant for working with nurse care managers in the roles that we've been designing. All right, I won't go into this to any detail, but this is also kind of on designing for implementation. And someday my fantasy is that some of the smart people here or elsewhere who are really great IT designers are going to just be excited by what we're doing and help us with this, because we are not an IT shop, but we know we need some really great tools to do this kind of work. So we do have a rudimentary proof of concept application. It's really a mashup, to be honest with you, of different apps and applications that are represented in those top boxes to help us do this work, because there is a lot of training, there's a lot of oversight, there is a lot of data capture and measurement involved to do this work reliably. So we do have a web-enabled, cloud-based model where we've got in each of those top boxes, we lease a software application as a service to do policy and standard version control. We have a way to distribute staff training modules from the cloud, push them out to iPads that the nurses are using now in the field. Same thing for patient education materials, including video content and things like that that are very engaging for patients. We've struggled with our own homegrown database, not because we are an IT shop, but because when you start designing new systems and processes, there's not much off the shelf that really matches exactly what you need. So we fumbled around with that and tried to do the best we can. And we have a pretty robust analytical capability I won't go into, but relates to those statistical process control charting capabilities and so on. Now, the thing about all this is that compared to the big world that Cam was talking about, this is basically an isolated island unto itself. It's not connected to any HIEs. It's not connected to any lab feeds. It's not connected to any EMRs. It's just us with a database, SQL database in the cloud, and nurses running around with iPads, and we have chart reviewers who go in and collect the data, and they enter it in our system so our nurses can see what's going on. It's crazy. I mean, it's really crazy. So when I get to the punchline at the end of all this, it's going to be how much better this could be if we could get to some of those system designs where it's integrated with the information. Okay. So let me just now flip to our case example. So we tried very hard to follow the kinds of things I just described to you as our approach to designing our program and implementing our program. And it's a program that uses nurse care managers in the community working very collaboratively with primary care physicians and acute care hospitals and rehab centers and community service providers. And we follow the patients once they enroll forever, unless they die, move away to some hard-to-reach place, or elude us in some way. But otherwise, we don't let them go, because the nature of the chronic conditions and the risk, we think, warrants that. So how has this been tested? The other really interesting thing I'd recommend to everybody is when you hear about models, population-based care management, care coordination, disease management, really pay attention to how these things have been evaluated. There is a broad scope of methodologies out there, not all of them very robust. I'm proud to say that we have been under the crucible of probably the longest running, most rigorous evaluation of these kinds of models to date. This evaluation is a randomized controlled trial at the individual patient level. So for folks that aren't familiar with that, it's like a drug trial for a pharmaceutical company. You get the nurse or you don't. Everything else is the same. The condition of the patient, where they came from, the primary care physician, the hospital they use, their socioeconomic status, et cetera, et cetera, et cetera. So you're really only measuring the impact of the model. When this began, there were 15 programs around the country selected by CMS. And then as we went through time, CMS lopped off more and more programs because of lack of impact. CMS now measuring impact by savings, how much money is saved and whether or not the program at least offsets its cost in terms of expenditures for Part A, Part B Medicare. So in June 2010, our program was the last one of the 15 left standing, and we had managed to get through these gauntlets, and now are focusing our work on the population described here. Over 65, fee-for-service Medicare, heart failure, coronary artery disease, diabetes, or COPD, and one or more hospitalizations in the preceding year for any reason, not necessarily related to those conditions. We've got over 90 practices that have been collaborating with us, primary care practices, all shapes and sizes. The little map on the inset is meant to kind of depict that. 4 counties in eastern Pennsylvania: Bucks, Northampton, Montgomery, and Lehigh. And in the extension that CMS has now asked us to expand into Philadelphia, Chester, and Delaware counties because of the effectiveness of the model to date. Over 2,800 people have been randomized into the study over the course of the study, and a different methodology has been used by Aetna. And I'll also mention that all of these analyses are done independent of my team and I. This is all third-party independent data review, including the Aetna work, which is done by the Aetna Health Economics Division. So here's the outcomes to date. For the folks at higher risk, there's been a 39% decrease in hospitalizations, 37% decrease in ER use. If you look at the gross savings on Part A, Part B Medicare, it's a little over $6,000 per person per year. After you take out program fees, it's about $4,800 per person per year as a net savings to Medicare. And I will point out that because this is such a long-running demo, these data represent an average of about 4.5 years of follow-up. So for each individual enrolled, you can take those numbers and multiply them by 4.5 and get kind of the net savings per enrollee. Nationwide, this higher risk group is estimated to be about 14 to 16% of all Medicare beneficiaries in the country. So there could be a potential, if we can figure out how to scale this reliably, to do something pretty significant on a national front for costs. And our proudest achievement actually has been the fact that the quality of life of these folks and the all-cause mortality has been significantly reduced by 25% if you include all comers on an intention-to-treat basis. The Aetna Medical Economics team found a similar kind of a pattern. After the first year of evaluation, they clocked it in as reducing hospitalizations about 20% and net costs 18%. This is same hospital readmission data. So Doylestown Hospital has been an incredibly strong supporter of our work. And they said, well, we have data on who gets readmitted, and you have data on who's in which control or intervention group. Let's match the data up ourselves instead of relying just on the CMS stuff and look at same hospital readmissions. So this is the data from that analysis, and it's about a relative 26% reduction in same hospital readmissions. For folks that aren't familiar with this kind of a plot, this is a Kaplan-Meier survival plot. So the top plot on the left is everybody that was randomized. And again, we count everybody in once they're randomized, even if they move away to Florida and don't work with the nurse. They still are counted in, which means we're not able to cherry pick anything here, right? So we're able to say, well, you came in, but you didn't really play well with the nurse, didn't work well with them. So we're going to exclude you from the data and make it look a little better. So that's not what this is. This is everybody enrolled. The blue line are the control group or usual care. The red line is the folks working with the nurse care manager. It's a 5-year follow-up after the time they first enroll. And what we're measuring along the y-axis is the percent of the group that has died. So for all in, it's about a 25% reduction in all-cause mortality. The middle graph is showing people who came in who on risk assessment when they were enrolled were already at high risk, had high geriatric risk. We use a risk assessment tool that's structured and validated and scored. And for those folks, there was a 34% decrease in mortality. For folks that came in because we do a lot of focus on cardiovascular risk reduction, the last graph is for folks that came in with a primary diagnosis of already established coronary artery disease. So for them, it was about a 48% reduction in all-cause mortality. So this is a pretty impactful program. You will be hard-pressed to find other devices, drugs, or other things that we spend a lot of money on that has no known side effects and has this degree of impact on people's lives. And it's principally by thinking differently and redesigning the delivery of a model of care about which we already knew what worked from prior research on prevention. We didn't create new knowledge in doing this. We just reassembled it in ways that was delivering it differently than we'd thought about it before. So I think it's a testimony to trying to push ourselves a little bit on the redesign aspect of how we do our work. All right, so how does this relate to HIT and HIE? As I mentioned before, we did all of this with no connection to any kind of meaningful data. Now, since in the last 2 years, since we've been working with Aetna, fortunately, we get lots of data from them. And it's been tremendous. I mean, imagine our nurses trying to figure out who to target, how often to follow up, intensity of service, and doing this by us going out and trying to collect data. It's silly. So the opportunity here for HIT and HIE, when meshed with good design, is tremendous, absolutely tremendous. But I think the cautionary note is the flip one, and I think, Cam may have been referencing that when she said, well, some HIEs will bubble up and go down and people will learn more and reconfigure. I think the ones that don't succeed may well be the folks that haven't given enough attention to how to design the delivery system to leverage the greater opportunity made available to them by having the information at their fingertips. And I think we can have all the bits and the bytes flying all over the place that you want, and if we don't think about that, we're not going to get the measurably different outcomes that we could and should get by the efforts that many of you are all working on. And I think that would be a shame. So whether you guys are on more the HIT side or other sides of this enterprise, this effort, I urge you to be proponents and champions of pushing people to think about the design of what are you going to do with our data? Okay, suppose we set this up for you. How are you going to use this differently than what you do now? There's been many, many, many papers that have looked at trying to push more data through the same limited sort of cognitive capabilities of a cardiologist or a primary care doc, and realizing that it doesn't change outcomes much because they're already overloaded with lots of data. So if we don't incorporate the work that we're doing around better information availability to designing the work of delivery, we're going to really feel shortchanged at the end of it. We're going to underperform. So I listed here a couple of the areas that I think are really ripe for harnessing the HIT technology: telehealth, chronic illness management, population risk monitoring, and dynamic at-risk population targeting. If we had dashboards where we have risk scores on people, and as soon as they bubble up and hit a certain risk score because of a new chronic illness or an evidence that they're not managing the one or two that they have well, we could be so effective in proactively preventing complications and save lots of money and improve outcomes and quality of life. Team models of care gets a lot of lip service, and it's now kind of in vogue now to talk about team models. But again, we do the same thing to team models that we do to so many of the rest of us in healthcare. Is we say, okay, create a team model, managers start managing a team model, and we don't design it. We don't define who's doing what, how they're doing it, what resources they have available. And so lots of team models are being pushed hard in directions that, despite all their best efforts, they may not be successful on if they're not designed, if the system isn't designed to support them. Okay, so I think, going back to kind of recapitulating, Einstein's admonition that we have to think at a different level to solve problems that we have today, I think design offers a really great way to do that. It's to step back, reassess what our big aims are, reassess the framework for getting to those aims. And as one, company famous for its design would recommend, it means we have to think different. So thank you all very much, and I'm happy to try to answer any questions. Thanks.
So I'm always struck by the fact that if we're decreasing healthcare dollars and decreasing death over time, are we really expending the same amount of money? It's just done over a longer period of time because patients live longer. If you really look at the number of dollars spent, a lot of it is the end-of-life care, which it really sort of doesn't matter where it happens. It's costing an inordinate amount of money. Have you guys done anything in an innovative way when you're partnering with a nurse manager so that end-of-life decisions are handled differently so that we're decreasing the amount of money used in end-of-life care and having more patient-centric decision-making in that space?
Yeah, I like the way you asked that question because this gets to be a confusing, contentious topic sometime. Everything from the one extreme of death panels to not really appreciating, as you framed it, that it's about helping people think more and be more supported in their self-determination on end-of-life decisions. So yeah, we spend a lot of time on that. The nurses, that's a key part of their work, and we're not trying to push people to hospice prematurely or do any of that kind of stuff to lower costs or any of that sort of thing at all. And in fact, despite that our survival curves are significantly better than the control group, we use hospice almost twofold more than the control group. So the CMS has looked at the claims data on that, and it's about twice as often we're using hospice as in the control. So using hospice doesn't mean people are going to live less long, provided you avoid that needless complication from an injury due to a fall at home and a hip fracture, or a stroke from blood pressure that's not well controlled. So we can do both. We can have a better, more humane end-of-life, less expensive end-of-life experience, and have higher functional status and fewer complications. Yes, sir.
You had a slide that had all the different components of your model and how they had evolved over time. Bringing this back to the HIT side of things or the HIE side of things, of those components, what percentage of those are delivered in a traditional healthcare setting of the kind that we would be reporting to those kind of things versus delivered in the community or in the patient's home?
Great question, and thank you for asking, because I have to say I'm a proud board member of Pennsylvania EHI, and my big driving reason for being on PAeHI as a member of the quality, representing the quality component, is exactly this, because there are non-traditional settings and environments where we're delivering this care, and if we don't build our systems around health information exchanges to make bidirectional data exchange to providers like this in non-traditional settings, we're going to, again, really undershoot the potential for what we could do with this. So I'm there to try and make sure everybody knows, like, don't forget all these little bubbling up innovations and redesign that are out there. So to answer your question, on average, for high-risk patients, nurses will have a bidirectional contact with them about 29 times a year. More than half, about 60% of those are in person, either face-to-face or in a group model setting. And of those, increasingly more and more are in the home. We also rent community space or have it donated to us from faith-based organizations or hospitals. So we see them in their neighborhoods nearby because they're not generally good travelers. So you have to be close to where they are to provide these services. But it could be in a community center, a senior center. It could be in the home. Could be in one of our satellite offices for health quality partners, or it could be in the inpatient center. It needs to be, I guess, I'm not sure I'm articulating this well, but the platform needs to be mobile, and it needs to connect these folks to wherever they're delivering that care.
I thought about that when you showed your web services diagram, because we're working as a vendor with, on the pediatric side, somebody who does something very similar for obesity management among children. And it's the same thing. There's some components the doctor wants to know about that integrate back to their care plan, but some are just activities the patient's supposed to be doing, and the doctor really just needs a synopsis of that, and then kind of managing the right volume and level of detail on those two different platforms is a very tricky issue, and I can see that coming up here as well in terms of how much do you really need to know about every little thing that happens in the field versus the bigger picture of how it feeds back into the care plan. So I think across many domains, this problem is going to come up again and again in terms of the mobility and the need to be outside a traditional healthcare setting.
Right, and thanks for making that second point, which I'll just reemphasize is a really great thing for you all to be thinking about, and thanks for emphasizing that too, is how much information and what kind of information about any of this do you want to send to whom? When we started in April 2002, the primary care practices we started working with were all wonderful. I mean, thank God most docs in this day and age still really focus primarily on trying to help their patients do better, because we weren't paying docs to participate in this. We said, look, we can give this to your patients. I said, okay, well, I'll test drive it, but you know, I don't want a bunch of paperwork and research and all that other stuff to take me away from my taking care of patients. And so when we first started, we said, well, look, you know, our nurses collect all this really cool stuff about the home and how they're doing on their weight management and all this sort of stuff. And they're like, no. Don't send all that stuff to me. I don't want to have to review it. I don't want to have to file it. I don't want to have to manage that data. Now, this is before most of the docs were starting to move toward EMR, but even now it's transformed to, well, patient-centered medical home, there's a checkoff box here for care coordination. You guys are doing a lot of care coordination, and I'm kind of helping you with that. How can I get some information on what you're doing so I can get a little more credit, deservedly, I mean, not because they're not doing it, on that checkoff box? And now we're thinking, what is the right kind of data feed that would serve that need but not overload them with a bunch of stuff that they don't need to know about the weight trends from weight class to weight class and stuff? So it is a really good question. Anybody else?
Ken.
How deployable and in what time frame could you deploy any of your insights or even the programmatic features into other communities across the country?
Well, that's a great question, and that's really where we are right now, trying to figure out the answer to that question. So we've been in 4 counties, which is about an 1,800 square mile region, 90 offices, all shapes and sizes and levels of sophistication in terms of IT and so on, and we're moving into 3 more counties in the region. We submitted some proposals with some other health systems around trying to replicate this at a geographic distance using the kind of a platform I was describing. And some of those were Innovation Challenge grants that only 26 out of the 3,000 applications have so far been funded. So we've not been among those, but we are talking to a number of folks and looking for an opportunity to try and test replication at a distance in a different environment. We've also been approached by organizations that have said to us, well, you know, it's not just Medicare for older people as a vulnerable population that could use this kind of a framework of design. It's urban Medicaid and other populations where this kind of thing might be helpful. And I used to run an AIDS center in New York at Montefiore Hospital, so I'm pretty familiar with some of the environment and patient populations. And I think it's true that this kind of thing could be very helpful, but again, you have to start from the beginning with the design premise of what you're trying to achieve and for which populations, and then go through that same work that I described around discipline design. But I think it could be very applicable. This approach and the framework for it could be very applicable to other vulnerable populations, and we're looking for opportunities to test that as well, but we haven't yet.
Ken? You mentioned your experience in the 90s and the payment problems that took place then, and given this experience as well, knowing with health reform coming down, it seems to me you're holding back. If you could design this thing going forward, is there enough inefficiency and is there enough opportunity for care coordination or reducing variation to make this thing work? How would you design it?
Well, I think we'd continue to do what we're doing, which is to try and take the data. I didn't bring any examples of the 200 process control measures we have, but we still have plenty of variation in our own model. So if you look at the data carefully, there are plenty of things that we're talking about every week. We have a design team meeting, talk about how to redesign, continue to redesign our existing design. So I don't know if that's a good answer to your question, but we think we got off to a pretty good start with the model we have, given the outcomes that we're seeing, and we can continue to build on that. It's interesting, as we've partnered with more systems and organizations and tried to make ourselves available to help them, a lot of them are very impressed with what they're seeing, and they don't actually doubt the outcomes data because, again, it's third party and you know, it's a randomized controlled trial and all that good stuff. But they look at it and they kind of say, well, this is a little more intensive than we were thinking of. You know, it's like in the Olympics, you know, the difficulty dive factor of 9.0, and we're looking for something around a 4 or 5 is our comfort zone. This looks a little too hard to do. We're like, well, we'll help you. It's not rocket science. I mean, we do a lot of things in healthcare that are a lot harder than this, but it's framing who's willing to really go at it, I think.
Ken?
Yes.
I was looking at your methodology, design, manage, measure, and improve, and I was connecting it back to CAM's Healthcare Transformation Roadmap, and it seems like the two would really complement each other, you know, tie those two together. And then I also like the way you saved the HIT and HIE at the end, because, you know, that's sort of the means versus, you know, the whole objective here is to improve the quality of care. But did you think about the relationship between CAM's model and your design methodology as being very related?
Yeah, I think any framework that is talking about the evolution of the enablers and the providers in ways that would engage or allow a conversation to ask the question, and again, I encourage all of you to do this in your roles, what's the design to do what we do differently? Okay, if we can empower you and enable you with more information about your patients, how are you going to use it different than what you do today, as opposed to, again, just kind of cramming it through the same limited capabilities of the same providers that are doing the same things they're doing today. It's not, we're going to really underperform if we do that. So I think it's a great complementation.
Hi, Ken.
Hi.
With the success of the program, what pressure was driven by the physicians? This was an Aetna-sponsored program, so some sort of gain share might have been involved there. But what pressure for those physicians who were dealing with other payer patients to implement the same model going? Was there any discussion with the other payers to say, hey, here's where we are with this, it's working for my Aetna patients, well, how about my Cigna patients? You know, was there any discussion there? I mean, I've been involved in a few of these kinds of things in other markets, and it's the same thing. If the payer takes the lead and partners with the providers and the facilities, that gets the activity moving, particularly around gain sharing. But, you know, for us to be successful as a country, how do we get this more broad-based?
I wish I had a great answer to that. I mean, Aetna, we pitched to all the payers. Aetna was the payer that stepped up first and most, I thought, you know, committedly to supporting this. Obviously, the feedback we get from a lot of the providers is it would be great if I didn't have to call 5 different case care management purveyors for different patients based on their insurance card, and could consistently develop working relationships with one team of people that are extending my primary care efforts out into the community on behalf of my patients. So I think the direction you're pointing in, which is similar to what the national state demonstration around the multi-payer advanced primary care demo was trying to get at, was like, look, couldn't we make some coherent framework out of taking multiple payers, but then designing a single best model for care coordination to work with the primary care folks? And I think that's a really important effort to continue to advance. With the innovation centers let 1,000 flowers bloom strategy of demos and pilots coming at us right and left, I think it's becoming increasingly hard for everybody to figure out how to do that. I mean, it's kind of a counterintuitive, ironic consequence, is that everybody's trying to figure out which piece of these demos and pilots they could have a chunk of. And once you become an owner of one demo or pilot, you're on the hook to show your model works. And so everybody's now jockeying for position about how their model can be supported in this. And so we're bumping into each other instead of saying, wait a minute, why don't we just get in a room together and co-design it together the way we know the population needs the service, and then build it together. So I think in many ways, to get to your ultimate goal and where I think we would be best off, is what we need is innovation in collaborative models. And maybe this is also overlaps with some of Cam's stuff. It's that, we need to get everybody in the room and sort of put down the immediate short term, here's my organizational advantageous strategy, park that off to the side, come in the room, start with the white papers and the vulnerable description of the populations we're trying to serve, and do that design together and create something that we can all feel we have an ownership in. Otherwise, we're going to be wasting a lot of time, everybody trying to outcompete each other with these things, and it's not necessarily going to add to a better model. Yes, sir.
Yeah, this may be related, but what are the challenges? I look at your statistics. I'm saying, no, why doesn't everybody do it? It kind of goes back to, you know, many years ago when we said, hey, CPOE was a really wonderful thing. Why doesn't everybody do it? And it really comes down to changing culture, it sounds like. I mean, how do we get the adoption rates higher? And I learned this, I think, at last year's Pennsylvania EHI, is that I think culture eats strategy for breakfast. I think I'm stealing that one. And, but I think, so, but I'll take it as mine anyway. But, I mean, that seems to be the challenge. I think the 800-pound gorilla in the room is that we're driven by physicians who don't want to change the way they do things.
Yeah, it's a great point. And I would say it's not just the docs. In fact, I think in many ways, the docs in our framework have been some of our most ardent supporters and bought into this. Although, to their credit, you know, a lot of them will say, well, wait a minute, you know, I get hawked with this kind of stuff all the time. I'll give you a test drive. You know, I'll give you my 3 toughest patients. If this thing works the way you say, then I'll refer more. And traditionally, that's worked out great for us, and that has allowed kind of an entree. And Everett Rogers, who talks about the, you know, science of diffusion of innovations, talks about, you know, testability being one criteria that helps people get the hang of this and accept it. But your point about culture and mental models, I mean, when I was privileged enough to give a 5-minute condensed version of this talk, if you can believe that, at the Care Innovation Summit down in DC for CMS, and Atul Gawande was the moderator, and in the after, you know, kind of presentation panel thing, he asked me that question about, well, what do you guys think are the big barriers to expanding this thing, making it more available? And I had 3 components to that answer, but my first one was exactly what you're talking about, and I described it as fixed mental models. We have these assumptions. If you remember one of my slides, I said the first thing we have to do is suspend a lot of assumptions about who contributes what to health outcomes. Because I have had docs on the one extreme say to me, your mortality data can't be right. And I say, this was an interventional cardiologist. I said, well, why not? He said, well, I'm an interventional cardiologist, and I don't have anything that has no side effects that I can reduce mortality 48% by for people with coronary artery disease. And I said, so? You know, that means isn't it great we have some other things we can do as well as your great skills and talents? And then I've had other docs who are serving underserved population, usually in areas where there's too few primary care docs, who look at this and say, are you kidding me? This is great. We should stop doing what usual care should be, you know, forbidden now, and we should only provide care to chronically ill folks this way, just like a drug trial would stop a trial. So I think those fixed mental models are really something for us to contend to. It doesn't help that these great results are buried in reports to Congress. How many people have ever seen a report to Congress? How many people would know where to go to find one? I mean, there's a handful of you guys here that are obviously very engaged in some of the, you know, advocacy and government relations stuff, but most people have no idea where this stuff is. If it's not in JAMA or New England Journal, nobody knows about it. And CMS, because we don't have access to the claims data, and this is all done independently by them, I can't publish that part of it. We are publishing, actually, we've been accepted to a journal for our mortality outcomes, which, you know, is a publicly available outcome that we can use. So we will be having something, but it's not well known.
So I'm going to stand up for the primary care physician because I am one, and Gus probably could echo this for me. But from the primary care perspective, I honestly don't think that a lot of it is fear to change as much as looking at it as an additional burden to an already undercompensated, overburdened primary care daily workforce. And so this is going to be a little foreshadowing, but my answer to that is if you build it in a way that reduces the workload to the primary care physician and improves outcome. And oh, by the way, most of us wouldn't even care if it's budget neutral, but if you can give us a little bit better payment, but reduce our workload, let us spend more time with patient care and what we want to do, people will do it. But most people see this coming at them, and your naysayers are like, oh my gosh, it's another thing for me to do that I'm not going to get paid to do, and I already have a hard time getting out of my office before 9 p.m. So if you build it in a way that it works, improves care, and is not an additional burden on the primary care physician, I think the uptake is there.
Yeah, and I think that's been our experience. Because when we started out, again, all the 90+ offices that are participating, it's all voluntary. They're not getting paid more. They're doing it because it's good for their patients. And the only reason it's feasible for them to do that is because we've tried to make it so streamlined and so friction-free that they're not additionally burdened. So the nice thing about this model is that 90 to 95% of what the nurses do runs in parallel with and complementary to and comports with the treatment plan the primary care doc has laid out, but doesn't depend on their constant feedback and approval to run it. The 5%, 7%, 8% of the time when they go in and they see a patient's signs or symptoms have changed and they think the doc really needs to know about that to make some other decisions, they contact the doc, obviously. But a lot of this can run in parallel as a support to that model, which I think is really important to not continue to burden the doc. And actually, I worry about patient-centered medical home and some of these other things because I think that some of the structure and design for those, it's just inundating the docs more than it could or should, to be optimal.
Building on the question, comment this lady just made, and looking at your really extensive program, do you ever look at and incorporate into the planning process sort of an explicit approach to the social contract between payers, consumers, providers? Because we've had a nearly unspoken but implied social contract for 50 years about healthcare. The role of physicians, the role of patients, what expectations were, quality standards, and now we're changing a bunch of things. We don't want, manual processes. We want electronics. We want transferability of information. We want ubiquitous access. We want best practices. We want all kinds of things that, to my way of thinking, is an unspoken change to the social contract in healthcare. Do you ever incorporate any of that, or maybe just a reaction to the question?
Well, it's very interesting because one of our key attributes for the design is to create an engagement with a patient and their family that's based on their preferences and needs. And so from that starting point, we try to be an advocate and to provide the preventive services we have, but to start with what their priorities are. So it's very commonplace that our nurses on a first visit will go out and somebody will be concerned about, say, a grandson who's in trouble with the law or unemployed or whatever, and they're not going to be focusing on, self-monitoring their diabetes and doing glucose checks. And so the nurses try as best they can to align services and resources, usually community-based services, to help that family address the needs they can so we can start from there. But it does spill over to the things that you're talking about in terms of how primary care and acute care and rehab and insurance companies have changed. I mean, one of the things, the first thing I get from my nurses when I ask them, what do you want us to say when we go back and have our next meeting with Aetna, is they say, we got to get rid of some of these copays for some of these services that these folks absolutely need, that if they got, we could keep them out of the hospital. If they don't get them, they're going to be paying 3, 4, 5 times more. And yet, from the health plan side, you can understand that unless you have a really astute nurse who really understands what people do need and are willing to engage, to just say, well, we'll pay for everything, that's probably not a model either. So there is this interesting interface of getting better at knowing what patients really want and need as a preference and figuring out how that relationship can be better defined with health plans and docs and stuff. We try hard wherever we can to encourage patients and their families to do their own advocacy, either with the plan, but more often with the primary care doctor to do the direct communication. But sometimes it's either overwhelming, they're fearful, or they just can't put all their own history pieces together. It's too confusing. So in those cases, sometimes the nurse will accompany the patient to the primary care doc office and help package that up for them.
Yeah. On the data collection side, you mentioned that the nurses are a critical component, especially in the home. Has there been any role for DME where it self-monitors and provides you with the direct feedback back into your systems?
It's a great question, Sab, and we are desperate to try to figure out a thoughtful design to incorporate more of that technology. A thoughtful design. We've had a lot of vendors come and throw stuff at us, and I say, well, what's that going to cost? And they quote me a price. I'm like, okay, so it's between my nurse or your box. I said, that's not going to work. We need both of these. So some of it's cost, although that's coming down a lot. And then some of it is just the real world realities of how this stuff hooks up in the home. And what we have seen is that, you know, at first blush, you might think that it should be no problem for people to stand on this scale and have that stuff electronically transmitted. And depending on where the scale is, whether the person can walk to the scale, whether they're steady on the scale, it's unbelievable when you get down to the nitty-gritty, some of the issues to really make that effective. But I will say that it's an area that we want to do a lot more R&D on, and I think there's a lot of potential there. I mean, one of the things I was stunned by with a recent debrief I had with my nurses, we were talking about heart failure, because heart failure is a really tough condition. And you know, and there's good data. The cardiologists have done a great job looking at, you know, daily weight monitoring and how it's predictive of readmissions, and if you catch it early and you can intervene. So we're really looking at this data and we're really scrutinizing it. And I said, well, why can't we just get these daily weights more consistently and quickly so we can proactively intervene? They said, well, you know, we have these barriers in the home, but we can overcome some of those. The biggest area, the most difficult location to do this well in, daily weight monitoring, any guesses? Close. Nursing homes. I mean, you got to be kidding me. They're in a nursing home, we can't get daily weights? We said, well, most of the time we can't get them to do it, and then when we do get them to do it, they write it down in the book and they don't call us even if they've gained 5 pounds, 8 pounds. Nobody's paying attention, triggering it. There's a tons of opportunities, So.
Sir, you had mentioned that your nurses typically have 29 or more interactions, half of which are face-to-face yearly. How do they document in the mom and pop shops or providers? Do they have access to the EHR? And also, how do they extract the clinical support data, the metrics? How does that work?
It's a really evolving story, because for up till now, a lot of practices or health systems didn't have much in the way of electronic medical records to use. Now they do, and now as we're moving into some of these places, we're asking that question of those systems. So for example, we moved into one big health system that has all their practices connected to EMR, and we had this discussion, well, what do you want to see as the primary care doc? What would you want to have flagged as on your notes or to-dos, and which things do you want level 1, level 2, level 3 priority, and how do we decide? And actually, we're having this discussion now. I don't know the answer to that, because we don't want to over-inundate them. Obviously, key things that are asymmetric communications that could be dealt with through an EMR is a perfect opportunity to do that, so people aren't playing phone tag and faxing stuff around. So there's clearly an important role to do that, and we're just trying to define it now. So I don't really have a good answer for you, but it's a hot topic of discussion. What would you like in your system? And we're trying to figure out if there's any way to not sort of double document our nurses doing it in our database on our iPads plus in their system, but more importantly, what is it that they really want us to be documenting? So we're starting to sort it out. Yes, sir.
So I have a question. With regard to your care managers in your medical home model, have you used a consistent care management solution which will connect into disparate EHR systems to be able to document and transmit that data back and forth?
Got one you want to offer up for us?
Yeah, I do.
All right. Well, we're open. We're very much open. As I had mentioned, the challenge for us, and I think the technology is probably there and we're just probably not fully aware of it. The challenge for us has been we're very obsessed with 2 things. One is to create our decision support rules for the nurses in the field. So if this, then that, conditional logic on something that they can easily use as a tangible signal on their front end. And the other is this pulling out data for statistical process control monitoring and performance measurement and variation. So if we had somebody who could help us figure out how to achieve those 2 main aims and have it mobile on an iPad, we're really interested. We have no money, but we're really interested.
Okay, I think we've got a deal going, Ken, over here. Let's give a round of applause to Dr. Coburn for his excellent presentation today. And also to thank Cam and to Ken for starting us in this journey in terms of where healthcare is going to go over the next 10 years. We have some time, so what I'd like for you to do is take a break. We've got some refreshments out there, and this is a good opportunity for you to meet somebody new. There's a lot of new folks here. Please extend your hand, welcome someone, and then please be back here at 11 o'clock. We're going to start with Tracy Connor talking about Clinical Connect. See you in a few minutes.